Good afternoon, everyone. This is Melanie Escher with the Arizona Telemedicine Program. Welcome again to today's webinar. And we're going to go ahead and cruise through my little intro slides. If you're new to our program, when you joined, your phone and your microphone were muted, but please use the Q&A in the chat for questions and answers. Please use that chat function. It is on the bottom of your screen, and you can put in some questions in there. We do have a post-webinar evaluation that will populate in a separate screen when we're done. We have CME credit available for this, and everybody's also will be able to get a certificate. All that information is in the post-webinar evaluation. Plus, don't forget, I will be sending a thank you email to everybody, and it'll have all that information and the links as well. So the outcome objectives for today's session. These were all sent in various emails, and you saw when we were registering. So I'm not going to read through it all, but just showing you. Standard disclaimer. Of course, the opinions expressed in this presentation on the following slides are solely those of the presenters and not necessarily those of the organization sponsoring the webinar. Do we guarantee the accuracy or reliability of the information? Probably not. We'll see. Our guys are pretty smart. All right.
It's a vote of confidence right there.
All right. All right. So please check our website for upcoming webinars and events. Of course, this has been one of the most fun webinar series that we get to do. I love working with these guys. And again, your opinion is valuable, so please go ahead and do that evaluation at the end. And if you haven't been a part of our session, there'll be instructions on how to log in for CME attendance. Otherwise, everybody will be able to respond to my thank you emails for your certificates. All right. And so for today, of course, we have Dr. Klotz and Dr. York, who will be presenting on mites, my little mighty mites. And I'm going to go ahead and have Dr. York speak briefly about our series here, and then we will get started with Dr. Klotz. Dr. York?
Yes. So I recognize a lot of the names in here, but if you are new and joining us for the first time, this is a lecture series we've been doing for years now at this point, we can officially say, on envenomations, intoxications, travel-related diseases. We had spent a lot of time our first year focusing more in the Sonoran Desert. We've really opened it up in this next year. But just re-emphasizing to everybody, as Melanie said, we love doing this. And a lot of, I think, our best presentations have actually been topics that you all suggested. So please bear that in mind as you watch this. If it brings anything up, please let us know. But we are trying to orient this towards all you folks that have been coming as reliably as you have. I think we've got plenty of EMTs. We got some emergency room folks. I think some veterinarians. Is that right, Melanie, that might be joining us?
We
So a
have,
little,
yes.
yeah, a little bit of everything. We're doing our best to cater to all of you, but it can be tricky. But let me see the next slide here real quick. So I would say the theme of this last year has really been, I think, more fun stuff, more the unusual stuff that's out there. So again, if you are joining us or you haven't been from us from the very beginning, we do have all of our past webinars recorded for you. I think the last evaluation we got, I think bees came up a couple of times. We have done one on that. I think we're looking at probably bringing some of those older ones back. So if you have seen them, there's any interesting angles or perspectives that you would like us to go more in depth on, also please let us know. But we are looking at maybe bringing some of those older ones back and maybe giving it a different kind of an angle or maybe a different perspective. But I'm going to leave the intros then to Dr. Klotz for his topic. This is absolutely his field that we're about to get into. And good luck to all of you. I think this is a squeamish-inducing one for sure.
We do have some videos that we'll be showing, which one is a little more squeamish than the other. Dr. Klotz, if you'd like to go ahead and show your slides.
Okay, I hope I'm starting the right one.
It looks good.
You're good. Looks good.
Okay. Well, good afternoon, everyone. Thank you very much for attending. I hope we can interest a few people in mites, which has been an interest of mine ever since my first year in college back in Colorado State, when I was a pre-veterinary student and took a course in acarology. So we're going to talk about mites, which is the study of, acarology is the study of mites. and ticks, incidentally, and the human diseases in North America that they are transmitted by mites. So the objectives of this talk are to discuss mites that are agents of these diseases and or problems in the US. By problems, I mean they're mostly dermatological problems and or allergies. But the most important mite cause disease in North America is rickettsial pox. It can be lethal, but rarely is, and is easily treated. We're then going to shift to scabies, which is a very common problem, and some of you have seen it already, if not contracted it on one occasion or two in dealing with patients. And here on the right, you see a picture of a female Sarcoptes scabiei, the mite that causes this disease, coursing through a tunnel that it is digested by eating the epidermis. And at the rear of it, in that yellow circle, are the feces, which are so pruritic that people just can't stop itching. We're going to talk about Demodex folliculitis, briefly discuss chiggers, and end with oak gall dermatitis, which is the most recently discovered or recently encountered nuisance problem for mites. So mites are small arachnids. They have 8 legs, and they're known as arthropods, which means jointed legs. And there are 2 large orders, the Acroformes, which are mostly mites, and the Parasitiformes, which include mites and all the ticks, which were historically grouped together in a subclass called Acari. However, recent genetic analysis has shown that these 2 superorders don't really have a common ancestor, so they're probably not related. You see here a schema of a mite, and this is typical for most mites, but we'll show you some that don't look like this. Here you have an abdomen to the right and a head. This is all kind of smushed together in one long organism. And protruding at one are the chelicerae, or the jaws, that can bite through tissue or human skin. There are 8 legs in the adult, 6 legs in the larvae. They have a tracheal system for respiration, which is 4. And number 3 are the salivary glands, which are the origin of the material that's injected into humans that causes redness and an allergic reaction, as well as neurotoxins and other enzymes, so to speak. Excuse me. All right, most of them are some shade of brown, but many species are red, which any of you who have been to the Midwest would know from encountering chiggers that these, even larvae, are red, but they're barely perceptible by the naked eye. So I'm going to stop share here for a minute, if I can figure out where to do that. Stop share. And Melanie's going to present a video of a mite, which is entirely harmless. It's actually found in our area, and some of you have obviously seen this mite. It's a velvet mite. And while you watch this rather cumbersome looking mite walk around, it's quite large. You're not going to miss it, but it only comes out once a year after a rainstorm in the early spring. And Larry and Melanie's collaborator and good friend, Justin Schmidt, who was probably the most famous entomologist when he died recently, actually did a study of these velvet mites, and it's published in, I think it's in Arachnida, the journal. And it's got beautiful photographs and an entire explanation of the lifestyle of this mite, which was entirely unknown before. That was, people wondered, why isn't it eaten by something like lizards or birds the minute it comes up? But it's not. But Justin knew why, because it's this brilliant red, as you see, which is a warning sign that something's wrong if you go ahead and try and eat this. So Justin took a nibble of one and determined that they tasted kind of like pineapple with habanero mixed in. He had to spit it out. And he discovered not only that, but he also found out that they make their life by feeding on termites, which are released, the sexuals are released at the same time these mites come out after a rainstorm. They land back on the earth, they have wings, this mite attacks it and eats it. But Justin was famous for that, for eating or tasting some of the prey of different animals. Okay, let's get back.
You can go back to sharing. Yeah, that little mite could not get in that hole at all.
I was gonna ask, is that intended or did he just get himself wedged
He got
in there?
stuck.
Okay, so let's talk about rickettsial pox, which I said can be lethal, but rarely is. And it's one of the mite-transmitted infectious diseases. And I've taken this from a case of 3 that was presented back in 2004 in a dermatology text. It was very well written. It had absolutely beautiful photographs. And so that's why I decided to use these rather than the 700 cases otherwise known to occur in New York City or 800 worldwide. It's not only in New York City, but it's that 700 cases of the reported 800 all occurred in New York City boroughs. But it's been found in Boston and Chicago and Philadelphia, in Africa, and other countries. So in June, excuse me, of 2002, a 66-year-old female was admitted for a workup of a 3-day history of fever and rash that erupted on the same day she was admitted. She reported seeing a blister on her right foot a week before, which she thought was due to a shoe rubbing on her ankle. She felt tired and weak, but denied headaches or other symptoms. She was on no new medications, and she lived in the Bronx and reported seeing mice in her apartment. That last sentence gives you the 2 epidemiological clues you need to know what you're dealing with, and instantly you do. Mice and New York City. The physical examination revealed a comfortable patient with a temperature of 102 degrees Fahrenheit. On the medial aspect of her right ankle was a tender 1 centimeter eschar. I'll show you a picture in a moment. This was assessed as cellulitis, and the patient was placed on intravenous clindamycin that likely did nothing. Examination of the rest of the integument revealed multiple papular vesicles on her chest, back, extremities, and lip. There was no inguinal or other adenopathy. So here's a photograph of the eschar, which is where this mite, Liponissoides sanguineus, bit her with this long tube-like structure with chelicerae at the end and cutting jaws. Whoops. And you can see in the center of where this papule was, it's all become necrotic and it's got this leathery scab, we would call it. But in fact, this is an eschar, dead tissue in this otherwise healthy tissue. It's a little bit inflamed now. And this was the point of penetration of Rickettsia acari, which is the rickettsial organism that causes this systemic disease that she had. So Liponissoides sanguineus is a common rodent mite on Rattus norvegicus and Mus musculus, which is the house mouse. They use these animals as hosts to feed upon. The bite, if the tick is infected, or I wouldn't say it's infected, it's if the tick has the rickettsial organism, will transmit Rickettsia acari. And the infections usually occur when the mice, which is the normal host of this mite, are destroyed or removed from a building, like in a big housing district in the Bronx or in Brooklyn. And they go in and bomb some of these areas. And then, I don't mean, you understand what I mean.
Bug
Yes.
bomb.
Bug bombs or mouse bombs or whatever they do. And they kill off a lot of these mice. They have nothing to feed upon. So they turn to their only alternative, which happens to be human beings and pets that are in the house. Well, that's how they end up infecting humans. But New York City remains an epicenter for this disease. It's easily treated with doxycycline. So the differential diagnosis of this problem, eschar, rash, fever, is one we've covered before, and we've talked about it, and it's common. But every clinician and EMT as well, there's no reason why you shouldn't know this, should be aware of these too. And we have talked about all of the ones that are shown in red here, but they include things like anthrax and plague, which there was a recent case in Arizona. But these eschars of like anthrax are usually much larger, and there's a lot of associated edema because that bacterium has two different plasmids which express two different elements of the disease. We talked about ORF in a young graduate student of the wildlife department who acquired ORF by wrestling with Rocky Mountain sheep. We're talking today about rickettsial pox. I had mentioned South African tick bite fever in the past. And there were two rickettsias that we covered several months ago. Rickettsia parkeri, which is now found in the southeastern part of Arizona, and R. philippi, which is the cause of California coastal fever. These all have eschars. And a brown recluse spider bite can cause an eschar as well. Honestly, it rarely does, because most bites are not even picked up by the person who's been bitten, nor do they cause any problems. Okay, so let's talk about something that's not lethal, and that's scabies, although it can be a big problem and maybe leads to death in some animals. But here you see on the left is a female, the ventral part, got her feet up towards us. And on the right, you can see a female we're looking at it from the dorsal side, and its feet are down. You can see the head section here in which there are these jaws right here. And they're used to cut through the epidermis, the skin of the human being. They dig these tunnels. They lay eggs. The eggs hatch into nymphs who then crawl out the hole that the female has dug and go form their own little burrows and start all this all over again. And these burrows are just unbelievably pruritic. This is a very contagious disease. It's almost as if you just look at it, you're going to end up with this problem. But we've gone through periods of time, particularly in our clinics early on, in which, I've shaken many a hand with scabies on it, only to learn after having done that, I should have been a little more careful, but I never got any. But here's the tip off to this disease. Down here is a schema from the CDC, which shows the areas of the body that are affected. And one that's very typical is at the base of the spine on the back in this area and between the wingtips. I forget what I'm trying to say here. Anyway, and however, as shown in these pictures, here is the most common presentation, and that's intertriginal in the webs of the fingers. Here you can see these lesions between the thumb and the first and the forefinger. And you can see that they're linear in shape. They're actually a line. And so this is common. People are going to complain of pruritus that just drives them nuts. The other common site, and one that should tell you that you might be dealing with scabies, is the volar surface of the wrist. In the center there, you see a foot, which has a variant of scabies called Norwegian scabies, in which the patient is unable to mount an effective cell-mediated response. We used to see this in AIDS patients with a very low CD4 cell counts, to the point that people suggested if you see this disease, please check an HIV antibody.
Wow. When I was just going to ask you about the burrows, so you can't normally see that with the naked eye. Is it just that small?
No, you can see that the redness is linear and there's swelling
Gotcha.
with it. But here you can see what you can do, and I used to do this for the residents and students, is to just take a drop of Indian ink, put it at the opening of the burrow, and it'll just be drawn in. And you can see it trace these burrows all the way. And this
Oh,
guy,
wow.
someone's palm here.
That's wild.
Okay, so I'm going to stop share here a minute, and Melanie's going to show you another video, and I'll talk about it while it's running.
That's the only one. Peace out. All right. Have a good one, ladies.
Okay, this is what we wanted to show was a video from dermal videography, but we couldn't. These are scrapings from a lesion of scabies, and you can see the Sarcoptes scabii moving around in there, but they've actually been scraped off of a lesion. They're all alive, and they tunnel, and they also, as shown in that very first photograph I showed you, drop feces everywhere, which is very pruritic. And here's an adult. It looks like we were looking at the ventral surface there. Here we're looking at the dorsal surface of a bunch of mites all crowded together there. You can see. And they can move fairly quickly, as you can see. I mean, this is not sped up or anything. This is real time. Okay. Well, thank you, Melanie. And I will reshare again. Okay, and scabies also occurs in wild animals and our pets. You may have seen it on dogs. It typically starts around the ears and the face and may denude the whole body, as shown here in a black bear cub, and led to its death. But it's common in red foxes and coyotes and wolves, all these canids. Okay, let's turn to a commensal mite of human beings. Commensal means It neither helps nor hurts the host, but lives on it usually all the time for its lifespan. On the top, you see Demodex brevis, which is found in the hair follicles of the eyelash. On the bottom is a female Demodex follicularum that is in the hair follicles and sebaceous glands on the face. Now, this particular one you may even encounter on occasions. It's common around the sebaceous glands that are around the edge of the nose. And the female puts her head first into the hair follicle and sometimes leaves the tip end of its body there sticking out. But it looks white. It's not a black head, it's a white head, if you will. Anyway, these things are usually not a problem, but you can find them. And it was one of the first first mites that I collected. I made an extensive mite collection in my acarology course way back when. And I was so proud of mounting this Demodex follicularum because my best friend from Italy gave me the sample. And any rate, it's harmless. So, but people will go to dermatologists to try and get it solved. Another commensal to hair follicle, just by the way, is Malassezia, which is a fungus that is also a commensal, but it can be a nuisance when it causes things like tinea versicolor. But it's easily treated with selenium and or ketoconazole creams. All right, nuisance mites of humans. Here's the worst, which is found throughout the Midwest and in Britain. They're called harvest mites in Britain, chiggers in the United States. There's the life cycle you can see on the top there. So it's adult, eggs, larvae, nymphs. But it's the larvae that are the problem. As you can see, they only have 6 legs. And here's a photograph of one here, micro photograph. And it's beautiful because it shows the 6 legs, the body of the mite, but also this long tube that's extending out of the head section of the mite. And this is what the chigger uses to stab into the skin, deep into the epidermis. It secretes enzymes and then sucks up the destroyed tissue. And that's what a larval chigger is doing here on the skin of a human. And here you see the results. These characters normally are out in the grass in midsummer. They can be numerous, but they don't even have to be that. But if they get on you or anyone other human, they'll start crawling upwards until they encounter opposition, like the waistband of your underpants or your belt or some other constricting device on the skin, in which case they plunge that tube in and start feeding. They leave, you don't know it, and then the following morning you have this red, very pruritic lesion that'll last for almost 2 weeks at the site where the trigger was feeding. Okay, and then one last mite that I wanted to cover was the most recent that's been really implicated in big epidemics, and that is the oak leaf itch mite. Its scientific name is Pimotes herfsi. But the first recognition that this mite was causing problems in humans occurred in Pittsburgh, Kansas, which is a little bit south of where I am presently. In 2004, where it is estimated to have affected about 19,000 people in this small community. They were all showing up at their dermatologist. That guy must have been inundated with patients. And the local physicians complaining of these lesions that itched beyond belief were present for almost 2 weeks on their shoulders and neck and face. And here's what happened. Here is the origin of this problem. This is an oak leaf, pin oak, which is important. It's probably the most common tree used in lawns and so forth throughout Kansas and the Midwest. And on it is a leaf margin gall. And this is a leaf margin gall. Inside this sort of folded leaf are larvae of a fly that has gotten here and laid the eggs. Now, Hymotes herfsi, the mite, then comes into the story because they're looking to feed on the larvae inside there. And they do. But they're just amazing at reproducing themselves. I mean, there were actually estimated to be trillions of mites falling on people in that one community. And the reason why that they're so fertile, so to speak, is because the female gives birth to live young, most of which are females. The males come first. They hang around the genital orifice and inseminate the females as they're coming or being birthed. So they're gravid from day one, and they're all out going to produce 200 or 300 young themselves. Now, if they've run out of these larvae to feed upon, which were from a fly, actually, a very small fly, they're going to fall from the tree leaves and so forth, and they fall upon humans or anything else that's walking beneath it. And the mites instantly start biting. You don't feel the bite right away, but it has a neurotoxin that just sort of paralyzes these larvae and allows them to feed on them at their leisure. But that neurotoxin, when injected into humans, causes a very severe eruption. Here you can see these papules and pustules are red. My particular reaction was a lot of urticaria, so I had a lot of swelling. And this just went on for weeks, and you had a hard time sleeping after you've had a dose of Hymotes herfsi. So that ends today's presentation on different mites. And I think Larry is going to share with us, how do we take care of scabies, the most common mite-associated disease in the United States?
All right, I'm going to switch over. Here we are.
Yeah, we have as you're getting that set up, we have a couple comments about, yes, our chat is working, and if you got any questions or comments. And yes, someone was asking, anyone else having the heebie-jeebies? And someone was trying to not to scratch while they were watching that. Yeah.
It is challenging looking actually. So Dr. Klotz, like looking at the lesions themselves, I mean, you can almost see sort of that tunneling there. Is there any data or any knowledge about the length of that tunnel? Can that indicate how long potentially you've had scabies or been exposed? Is there anything there? I mean,
Well,
what does that
it
look
all
like?
starts with a female getting on a naive person and then beginning to burrow and tunnel, lay eggs. The eggs hatch, the nymphs go out and start their own burrows. So we're having an increasing number of burrows.
Oh, wow.
That initial female one, as I showed you on the palm of that hand of
Yeah.
someone I looked at, you can see they're quite long, actually. They move right along.
Yikes.
And you can see the host response in someone who has no cell-mediated immunity in those patients with the Norwegian variant of scabies.
I like the buildup. Now we're going to deal with these nasty things. Now that I can feel the Demodex crawling everywhere. All right, so we're going to talk about scabies treatment.
Don't worry about the Demodex.
I'm worried about everything at this point. What are you talking about? This is always one of those ones you see the videos and you become acutely aware how much stuff is living on us and what it's doing to us. All right, but managing scabies, there's, I think there's a lot of questions that we still don't have solid answers to, but at least in the US, management does tend to be pretty straightforward. I'm sure we've all seen some combination of these drugs. But in today's age, you're going to see some combination of topical permethrin, 5% usually, oral ivermectin, and that's usually about 200 micrograms per kilogram. And it ends up being a fair few pills. It usually comes in 3 milligram tablets, so I'll see folks getting anywhere from maybe, I don't know, 3 to 5, 6 sometimes. It just depends on the individual. But I think what's most interesting about this topic is that a ton of other stuff does exist for the management of scabies. Now, I'll mention one that did actually get approval here, but a lot of these are not readily available in this country. You're more likely to see them in developing countries, but a quick Amazon search will tell you you can probably get your hands on them fairly easily if you'd like to. But looking at topical permethrin, this is a 5% product, as I mentioned, head to toe. Now, it seems silly, I think, to just keep saying that, but it is truly head to toe in most individuals, and I'll be even more specific in a second. But you're going to slather this on, leave it on for about 8 to 14 hours, and then wash it off. And we'll mention here in a second, head to toe means every nook and cranny. So not just between the fingers, the toes, under the nails. You want to leave no stone unturned here, just in case. There's even cases where someone may have 10 to 15 mites, and that's enough for them to have a reinfection or a failure. So always making sure that that is being carried out to the letter, every inch covered. How it's working, and this is a similar through line for all of these drugs, is they're, in this case, it's a voltage-gated sodium channel, but you'll see GABA-related receptors, nicotinic receptors that are getting affected. Essentially, all of these are leading to paralysis, excitation in some of these mice, and eventually death. Now, the thing that shouldn't be overlooked, and as Dr. Klotz mentioned, these are laying eggs. And the issue is some of these products are not inherently ovicidal, and even the ones that are may not be the greatest at it. So often some of these compounds are really focusing on these actively moving, doing things mites. You might get some activity with the eggs, but not always. So you do often see these products recommended to be administered usually about 7 to 14 days later. And that's barring for how long it may take for those eggs to then essentially result in an active mite that's going to go about doing its business, that you're going to do a second sweep, hit everything that you missed the first time. And we will get into some of the numbers for, well, how long should I do this? How long should I do that? There's a fair amount that can go into this. Now, permethrin resistance is something that's interesting when you go looking at it in the literature. How much of it is really resistance? Now, I'm not saying that permethrin resistance doesn't exist. It's clear that it does. But often what you're really dealing with is pseudo resistance. And it almost usually is they're not applying it everywhere. So I always like to get an idea of, for something like this, as Dr. Claude Smith, this is very common. I mean, probably among us here, someone's likely had a run-in with these things. The main thing I think about now in today's day and age is if folks got to treat themselves or have questions, they're going to go online and you're going to find a lot of wacky stuff on some of these websites, Reddit, Quora, a lot of different things. And to be fair, there are folks out there, the one that stuck with me, and it's, chuckle about it, but it's a consideration. Oh, I didn't want to apply it to my testicles. I'm afraid it's going to have an effect on me. And it's just emphasizing, no, you're covering everything with this topical product. So I emphasize that more just to reiterate, I think patients, you can tell them everything you want. But when all is said and done, if it is not explicitly clear, a lot of these failures end up being they didn't quite get every nook and cranny. They were a little hesitant to go into certain places. They weren't sure how that would necessarily work out for them. So just really emphasizing head to toe. Oh, let's get this going. There we go. So a couple of tips for permethrin, again, leave nothing uncovered, but also warning folks that the rash or the itching may actually worsen at first. So this was another comment that I did see popping up frequently on a lot of these websites is, hey, I just started treatment and I feel worse. Is this not working? What do I do? And we're gonna mention something similar here in a second, but similar to, I always use comparators like tumor lysis syndrome, treponema pallidum syphilis has a similar phenomenon. You're wiping these things out very quickly when you apply these drugs, and you're starting to get these immune-mediated reactions to all of the dead components that are now filling up in these places. That combined with permethrin can be a bit irritating when folks put it on the skin. It is not at all unusual when folks first start applying this that it actually may look like things get worse. That's okay. It's not an uncommon thing. Go ahead and continue with the treatment. But that does bring us to oral ivermectin, which, coming from a stewardship background, if I don't have to do a systemic treatment, I don't always like to. But granted, permethrin does have its issues too, certainly in kids. Are they really going to leave this product on 8 to 14 hours, not smear it or try to get it off? It's a fair consideration. And oral ivermectin is at least a dedicated option if you just want to get a treatment done. You know that it was done, and the rest tends to take care of itself. Now, ivermectin, the issue for me really just has been a pill burden thing. Now, this is essentially a 2-dose thing. I should correct myself. So it's not the worst thing in the entire world, but the pills can add up pretty quickly. Now, from a pharmacy standpoint, it is just a straight weight-based dosing. There is at least the question and some data out there about using total body weight. I would say there's enough kinetic data that, yeah, probably in folks that are more obese, you're gonna probably overdo it a little bit with the ivermectin. The issue is there's just not a lot of data to really guide, well, what's the right thing to do. And certainly for the indication we're using it for, if you do tend to overdose in that regard, the ramifications are pretty small relative to maybe some other conditions ivermectin would be used with. Now, similar mechanism, it is working here instead on a glutamate-gated chloride channel for these parasites, but it essentially leads to the same effect, this excitation, paralysis, and eventually death. Now, the big difference with ivermectin is it really does have next to no activity against the eggs. So I would say this is a dedicated, you should repeat this after maybe 7 to 14 days just to make sure you get that second wave that comes through, wipes out the newly present mites that have probably cropped up. The benefit, of course, here is resistance is pretty limited. Ivermectin usually is a solid option to go with. Now, some tips here. It does come in 3 and 6 milligram tablets, so you double the dose and you triple the price. I don't know that I've ever seen anyone get a 6 milligram tablet. So just rounding to the closest 3 milligram dose, you can overdo it a bit. It's okay. So whatever you're comfortable with for the patient. Here, similar to that reaction I was talking about for tumor lysis syndrome or Yarish Herxheimer reaction for syphilis, we've got a Mazzotti reaction for ivermectin. Similar idea that the effects that you get from ivermectin use can very quickly to lead to some of those similar symptoms of almost like a seemingly hypersensitivity reaction. The thing that I would want folks to be aware of, though, is that really seems to be more linked for the use of ivermectin with more filarial diseases, so more worms or other parasites. Very unusual to actually see that for scabies treatment. And if it does occur, it does tend to be pretty mild. probably more analogous to applying permethrin and getting a bit of a worsening of the skin that resolves pretty quickly, probably what I would expect. Now, neurotoxicity is a concern for ivermectin. It does seem to be much more prevalent in animals than humans. I don't know if we've got any vets or vet adjacent folks in the audience with us today, so please correct me if I am wrong. I am not an expert. But my understanding is cats in particular have a much harder time with ivermectin. It's much more toxic to them. And part of that, I think, is due to their ability to clear it. It's as related to as well to P glycoprotein effects. So in some cases, it doesn't really do a great job of keeping ivermectin out of the brain or the CNS, and folks can get these more neurotoxic effects for sure. So here, a surrogate that's used is a body weight less than 15 kilograms, sort of a roundabout way, but it's really targeting folks that are not expected to have a fully formed blood-brain barrier. That's really what they're looking at for these lower body weight individuals that you might be treating. Now, food increases the bioavailability, and the only reason that I mention this is some experts I'm seeing, normally we would have folks just take ivermectin fasting. But because food increases the bioavailability, there's some experts that will say, well, no, I'd rather you get a better exposure. Why don't you go ahead and take it with food? This is, again, one of those things I'd file away with. Do you really need to do that? I would wager likely not in general scenarios, but that does bring us. So crested scabies is the term they're trying to use now, but this is Norwegian scabies. It is this more severe infestation. So what you were seeing in those pictures are more these hyperkeratotic lesions caused by the mites that are present there. There's some cases where folks with limited mobility couldn't scratch, and you started to see that irritation essentially build up and become this crusted or Norwegian scabies. And this, other than being more aggressive, it is more difficult to treat for sure. So this is where a combo approach definitely makes more sense. Doing the topical permethrin, doing the oral ivermectin. Now, again, very quickly we start to go a bit off the rails in terms of what's the best way to do this. There's a number of ways you can. So this ivermectin dosing, it is repeat dosing that you're going to be doing. And it boils down to which is right. 3 doses, 5 doses, 7 doses. How bad does it look? If in your mind you look at that thing and you think, wow, that is one of the worst things I have ever seen, or they have a background of being immunocompromised, hey, the 7 days makes sense to me. But that is genuinely what it does come down to, is it's almost a gut feeling about how many you have to go. There's not really great data parsing out the different intervals or numbers of doses. Now, an interesting thing, I think outside of dermatology, I know this is not the first thing I would probably think of, is combining it with a keratolytic. So like urea, ammonium, you can combine it with these products that may help get rid of the crusting a little bit faster. So you might be able to get a bit more relief with administration of some of those products too. So don't try not to overlook, but easy to forget. Now, limiting the spread, this is the one that I think is worth a decent conversation for folks. Let's say that Dr. Klotz, turns out I see the burrs, or I do some India ink in them, I see the spots, I can tell that this poor man has got scabies. But let's say his household contacts seem completely fine. I would still opt to treat those individuals. Now, like any allergic reaction, the first time you're exposed to something, it may not be an immediate thing. So as folks that are first infected or infested, I guess I should say, with scabies, you might not notice anything for maybe 4 to 8 weeks. There's not an immediate giveaway that something's wrong. So while this individual already has clear signs of infestation, that doesn't mean that the individuals who are currently asymptomatic are without mites. You would go ahead and just assume, yeah, if there's been close contacts, skin-to-skin contacts, household members, it is probably worth it. This does extend to sexual partners. So in our clinic, we have a PrEP clinic where often we see individuals that do have multiple partners. This would be I might notify everyone that you've had this exposure to and let them know just to get tested. Or evaluated, I should say. Testing's a different matter. So, as far as treatment goes, how it affects work or school, all of that, once you start the treatment, I would at least take the day, give it 24 hours. But once you've gotten started on treatment, you're likely good to go back to work. Now, crusted scabies, I'd say take that day by day. But your run-of-the-mill scabies cases, you don't have to be completely knocked out and miss a lot of work if that's going to be an issue. The main thing, though, is circling back to you can't just treat these folks. I mean, we have to assume that these little bugs are everywhere, and we got to do a couple of things. So certainly vacuuming, washing clothes, especially things used over the past few days, definitely getting it on high heat, even drying it for about 10 minutes is enough to totally wipe these things out. The trick that I think probably everybody in this room knows is things that you can't wash or you for whatever reason, you don't want to either dry clean it or do something with it. Slapping it in a bag, putting it away, set it and forget it, like the old infomercial. Give it maybe 3 to 7 days. Depends on the individual you ask. Typically, once the mites are removed from the body, about 48 to 72 hours, they're gonna crap out on you. But there are some cases where maybe even up to 7 days, some of these crusted scabies cases. So I leave it to your recommendation of what individuals are able to do. I think after you get a presentation like this, it's hard not to just assume clean everything with fire and leave it out for the next month. I would completely understand that sentiment. But you don't have to go all out. You don't have to change mattresses, anything like that in most cases. So the CDC does have a great reference for if we have any folks here that do work with care homes, what to do if there are outbreaks. Pretty similar between scabies and the crusted or Norwegian scabies, not a lot of difference. So just wearing gloves, if you have to have that skin-to-skin contact, washing your hands thoroughly afterwards. If it does start to spread, individuals on the staff that were exposed, both treating them and, of course, close contacts, household, family members, that sort. But again, there's typically no need for changing mattresses in most cases. Now, managing the itching, this is pretty straightforward. In most cases, just an oral antihistamine is probably good enough. Even just what we're already doing for allergies. I could take a cetirizine, a loratadine, a fexofenadine. It might be good enough. More severe, maybe consider a Benadryl or a diphenhydramine, but there are certainly cases, topical steroids, oral steroids, depending on how severe it is. I may not be completely shy about it. And the main reason for that is Dr. Klotz had alluded to. There can be mortality connected to scabies, but not in the way that we think. Really, the constant itching that is induced by these things leads to these secondary bacterial skin infections, and there's a surprising number of cases of uh, glomerular nephritis issues relating to some of these things, rheumatic fever. In an Australian study where this comes from, I got the article down below. 2.5% mortality in folks that came to the hospital with crusted scabies because of these other issues that they then subsequently had. So again, I think emphasizing genuine skincare in managing the itching is huge for these individuals. Now we're about short on time, so I'm just going to very quickly mention these. Sulfur ointment, let me take a step back. So sulfur ointment, you're more likely to see used probably in kids under age 2. Permethrin officially is not recommended for folks under the age of 2. With that said, there are surveys out there. There's plenty of dermatologists all over the country that do still use permethrin and still cite it as their preferred agent of use. So take that what you will. I'd invite you to look at the data yourself if you're comfortable with it. But oftentimes, these compounded sulfur ointments are the workaround in those cases. This is a product you could get on Amazon. I was able to find actually a fairly decent looking item on there. Now, lindane, just to briefly mention it, this is a pretty darn toxic thing. It is not really recommended anymore. This is the equivalent to ingesting Raid or whatever you use to spray your crops out there. It's not recommended to do it. Same for malathion. Not maybe the best thing to be taken. For malathion in particular, they really only recommend maybe just do this once. Maybe don't do the repeat treatment. We're worried about you having a seizure from this stuff. So don't spray Raid on yourself and maybe leave these poor guys as your absolute last line treatment. I don't think you're going to need to get there though. Now, I'm going to skip over this one here and come back to it, but Crotamaton, also another product that's out there. All of these have plus minus efficacy compared against something like permethrin. Some look on par, some not quite as good. But this is typically more something that you're going to see in developing countries, or you might see someone that has ordered something online. Benzyl benzoate arguably might be better than permethrin in some given circumstances, given concerns about resistance. I was also able to find this product online. You can order it on Amazon. But circling back to the Spinosad topical suspension, this is actually approved in the US. This, to me, at least in my tier list, exists as maybe this really is resistance. The ivermectin, the permethrin's not working. Maybe I'll try this Spinosad. And all of these varying different mechanisms of action, some, like I mentioned, do affect GABA-related channels. Spinosad is different from permethrin, ivermectin, so cross-resistance is not really thought to be a thing, which is why I keep it in my back pocket. I cannot say I've ever seen it, to be honest with you, but that's probably my next line if someone is not doing well on ivermectin and permethrin. But in conclusion, this is not an unusual thing. Probably right now, 200 million people have scabies. Treatment is simple enough. I really, again, just to reemphasize, the issue is usually patient error. And I think it is just emphasizing get under those nails, get everywhere that you can to get these things covered. The itching can take a while to get better, even the redness in some cases. So if there isn't really a resolution at 4 weeks, that's where I would say either treatment failed or you were already re-exposed. So again, don't always jump to, was it a treatment failure? Did they do the proper things at home? Did they clean the things they needed to clean? I think appropriate management of this does involve really getting the nitty-gritty of, well, how did you take care of everything else? Itching, absolutely not something to be overlooked. If for nothing else than just pure relief from the insanity, this is always a great thing to manage, but it actually can have some significant benefits in terms of preventing some of these sequelae of itching the heck out of one's skin. And that is all that I have got on this. Hopefully exhaustive. Not a lot to talk about here.
So we have a question. When we were talking about right before you started, Dr. York, can bug spray work against various infestations, whether it's the scabies or the oak, the oak leaf?
No.
I will, yeah, I knew that someone was going to ask that. That's why I made the raid joke, but I
Okay.
cannot recommend doing that. No, don't do it.
Well,
Dr. Klotz, what about your
the
mites?
oak leaf gall mite,
Yes.
it's not going to help because it's bitten you and left the body. It's not on your body. It's already gone and it's already injected, um, neurotoxins and whatever. But I just like to say, I mean, I make rounds with Larry and we've known each other for years because he's in my clinics and we've had clinic together. And I mean, this is typically Larry just covering things beyond just the question, but
There's always more.
everything that's,
Gotta dig deep.
I mean, I learned a lot about your presentation that was supposed to involve only ivermectin. By the way, that's pretty limited to the use of onchocerciasis.
Yes, and that's where you're
where-
more likely to see those reactions.
Yeah, that Mazzotti reaction.
Yeah.
Does it actually occur with people who are taking it for
So they will subdefine it
babies?
as a Mazzotti-like reaction, and it's like a localized mild rash. Yeah, it's not what you would see more severely.
Okay, we got a couple more questions. What about using insect repellent, like Dr. Ampel talked about with mosquitoes?
Well, that's a very good point, is you can get clothes that are already pre-treated, or you can treat with permethrin, and that does go a long way to help and prevent, or at least benefiting in keeping some of those things away. That is a great approach.
Another question, I've heard this before and I've used it. Does clear nail polish actually do anything? Or is that just an old wives'
Chiggers?
tale about chiggers and getting rid of the
Yeah.
itch?
No, again, it's the mite has already left. By the time you sense something, it's already gone. So there isn't anything to kill or get rid of. You know, it's just the results of the toxins that were injected, the enzymes that were injected deep into the tissue.
What about putting it on once you've got that redness and it's itching? Will clear nail polish help stymie that itch?
Oh, I remember this clear nail polish when I was in my teens, you know. That was when we thought the bugs were.
Wow. Yeah, I don't know anything about. I've heard these rumors, but I don't know if
Well,
there's
that's
evidence.
dating us then, yeah, because that's what I grew up with too, was the clear nail polish.
Interesting.
That or the pink calamine lotion.
Well, that calamine lotions actually divide to reduce itching,
Okay.
but it dries and stuff, and it's kind of an astringent.
And then I've seen the Benadryl sticks for like mosquito bites and things.
I feel
No?
like topical Benadryl, I don't know that it buys you a whole lot. It
Okay.
just take a Zyrtec or something. It's gonna do a lot better for you, probably.
Great. All
I
right.
don't know that I've ever seen topical Benadryl make a major difference.
Okay. All right. Again, thank you for joining us for another exciting, entertaining webinar with Dr. Klotz and Dr. York today. Please go ahead and do the evaluation, and we will be getting, I'll get my thank you email out to everybody that has attended today with all the other information and the links, so you can do your evaluation, respond to that, so I can get your certificates ready for you. And a special thank you to all of our new participants that have attended today. Double check our website for upcoming sessions. I believe we have some folks from the College of Veterinary Medicine that joined us, and we have a new group that was interested from Border Patrol out in San Diego. So if any of you folks were able to join
Ooh.
us today, it was a quick information from an email the other day. So hopefully you were able to get along with us today as well. All right, everybody. Thanks again for joining us. Dr. Klotz, any final words?
Yeah, I was just going to say, you want to announce next month's webinar?
Would you like to? You're talking.
Yeah, this is
No,
a good
I'm not
one.
talking. Neil Ampel is.
Oh, Doctor, you're right. Dr. Ampel's talking. All right, the word escapes me because it's about this long.
Melioidosis.
Thank you.
This is an odd one. A lot of you,
Hercularia.
and
Yeah.
a lot of you folks in the comments have made comments about like getting the histories and the questions. And this is a hallmark of that. I think this will be a really fun one.
All right, so I will have that link in my thank you email, everyone, if you haven't signed up for that one yet. And we will see you next month, everyone. Thank you.
All right, bye. Thank you, Melanie. Larry.